Good afternoon and good evening. Thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret Edwin, the Director of Communications. I'll be moderating this session. The weekly briefing focuses on advancing the Africa's health security and sovereignty agenda, including the health emergencies across the continent. And today we are joined by Professor Yap Boom, the Deputy Incident Manager from the Incident Management Support Team based out of DRC. And just to let everybody know, we have French translation on channel 2. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof. You are muted.
I was so excited to start that I not realized I was muted. Thank you so much, Director Margaret. So good morning, good afternoon, good evening, wherever you are. It's my pleasure once again to lead this press briefing on behalf of our Director General, Dr. Jean Kasseya. So taking the briefing from Kinshasa, where we are gathering as partner to really think how will be the future of the preparedness and response to public health emergency in the continent based on all the lessons we've learned from Mpox. But also it's an opportunity to thank you, journalists, but also scientists and public health experts who are joining or who are watching this press briefing. It's quite important for us to have all the feedback, the comment that you put on our social media so that we can consider your question and make sure that we provide the right information to you. Over to you, Director Margaret. As mentioned, we are here in Kinshasa, where we are discussing how we are going to transition the Mpox from the emergency to the routine. What were those lessons that we've learned on how at the continental level we responded to this outbreak? We'll come to that later. But this week has also been the opportunity for quite significant engagement that has been happening. This one, you can see the high number of people that were attended this critical workshop on advancing primary healthcare digital framework. So this was under initiative of Dr. Jean Kasseya, our Director General, together with the Minister of Health in Ethiopia, Dr. Megdes Daba, to convene the African Union member state, but also partners, technical institutions, to validate the primary healthcare digital framework. This is a critical foundation on how we are going to strengthen to scale our primary healthcare in the continent. And this is very well aligned with the Africa Health Security and Sovereignty Agenda to ensure that we strengthen the implementation of the coordination, but also, and critically, the accountability to advance stronger primary healthcare system across the continent, which include how are we going to provide that accountability to our champion, every champion who are leading that initiative. Next slide. It was also the opportunity following the engagement of our DG and the leadership last week in Tanzania to follow up with the Minister of Foreign Affairs and Deputy Minister of Health from Tanzania to elaborate more on the support that the President Samia Suluhu Hassan of the United Republic of Tanzania will provide on her new role of African Union Champion of Maternal and Childhood. You remember that was one of the key highlights of the recent African Unit Summit. So the meeting really focused on strengthening the cooperation to advance health security, particularly on that aspect of maternal child health, but also the resilient health system. If you remember well, Tanzania was one of the countries that have been responding to several outbreaks, including Marburg outbreak, but also going back to the community to ensure that there is an equitable access to health services in Tanzania and more broader in the continent. Next slide. As you will see in the next slide, it was also an opportunity to strengthen the relationship with some of our key partners. Here is the Japan Institute for Health Security, and later on the European CDC on our core activities, which are on the surveillance, the research, the workforce development, and to strengthen our collective capacity to prevent, detect, and respond to health threats. Because whether we are talking about the collaboration with the Japan Institute, next slide, or the one with the European CDC, it's the same model where we are having those MOU to ensure that we have that interconnection with all the organizations leading the PPPR across the globe. So we've been working together with the ECDC here, for example, in Kinshasa for Mpox. We've been welcoming some of the colleagues. More recently, again, during the Ebola outbreak, they were there with us, moving to the field or sometimes involved on data analysis or any other activities. So that key partnership has at some point to be formalized, which was done with Dr. Pamela Randy-Wagner, which was the director of the European Center for Disease and Prevention Control. So it was also an opportunity for our partner to look at our institution, to look also at the center, the EOC, and all what is put in place at the level of Africa CDC to ensure that we have all the capacity to lead the continent with the support of our partner who will support on some of those areas, which include, for example, capacity building on some of those key pillars of the surveillance. Next slide. Still on the capacity building, the capacity building happened at different levels. We've mentioned what we do at the continental level in our headquarters, but now also how we strengthen the capacity of our member state. And the AVOC, which is the African Volunteer Health Corps program, has been supporting significantly the response to public health emergency. During the Mpox, we've deployed more than 2,000 community healthcare workers who are supported by the AVOC, around 100 AVOC divided by DRC, Sierra Leone, Burundi, Uganda, and so on. And those ones are the ones who are leading some key functions, surveillance, IPC, risk communication, and community engagement, ensuring that the country has the capacity to respond. So this week was an opportunity in Ghana to train some of those key volunteers, but also in Uganda. Next slide. Now, I mentioned that I'm taking the briefing from Kinshasa, where we have been working since Monday together with our colleagues from WHO, UNICEF, IFRC, Gavi, and others, ATI, USCDC, to review the IMST performance. So we did a survey across the partners, but also across the member states to have a proper understanding of how we've been doing well, what has been less well, and how are we seeing the future. So really, it's an opportunity to capture those lessons, also to transition from emergency response to permanent preparedness and response platform, because the IMST is the response platform. Now, the need is, together with the colleague of preparedness, see how we come out with a joint framework, which includes the preparedness and the response. So ideally, we are moving with those discussions, those conversations toward one continental platform for emergency preparedness and response. Next slide. And we want to believe that the outbreak has been a great opportunity in terms of this structure that we are building, but also in terms of research. This article was published early this week in the Lancet ID, emphasizing how research has a key role, especially now that we are moving from emergency to integration of Mpox. Through the 48 plus studies that has been happening across the continent, and many more than that, we've been able to gather quite a number of information and evidence, whether it's on the diagnostics, where we see that there have been some progress on the rapid test, though the performance is not yet what we want. But we've also learned a lot on the vaccine effectiveness in adults, in children, to see what are the best strategy for them to be implemented. But in terms of treatment, unfortunately, though we have been having some of those research on tecovirimat, which showed not to be working properly or adequately. There is one study, the MOSAS trial, which is ongoing, but we need much more evidence so that we have the whole continuum of diagnostic, treatment, and vaccine effectiveness. But what we also realize is that it's critical for the African scientists to lead the research agenda. And the 5 priorities that has been highlighted, looking at the scope of the prediction that we've seen, is to accelerate the clinical trial in endemic population. That will provide us the evidence on therapeutics, but also more that we need on vaccine and the different strategies. As we push the mpox control in the routine, clearly we'll need to have more accurate rapid diagnostic tests that can be used at the level of the community or at the level of the district. In terms of vaccination also, as we are thinking of moving toward a herd immunity where we have a large number, 60% of the population, in endemic setting, not everywhere, but in endemic setting, who will be protected, it's critical to ensure that we have the most adequate strategy, because we know that the vaccines are quite expensive, therefore we need to use the best of them. And last but not the least is to keep on strengthening the African leadership and research capacity, because we also appreciate that in some of those large studies, the African scientist was not the first author or the last author, which is also raised the need to keep on strengthening the profile of our scientists so that they can lead and tell the story of what is happening in the continent. Next slide. Now, going back to our public health event, cholera keep on leading in terms of number of confirmed cases, but also the number of deaths, as you can see, 438, followed by the measles, 315, mpox with 104, with 22 members affected. And then we have Lassa fever, that is in 6 countries, but you can see the high number of people dying of Lassa fever. So these also remind us that following the political engagement that happened in West Africa, there is a need to accelerate the support in that part of the continent on the issue of Lassa fever. Diphtheria is also, we can also see an increased number of suspected and confirmed cases, and also a case fatality rate that is around 10%, which is pretty high, and therefore need to have that coordinated approach and see how we can move forward. Next slide. Now, in Namibia, we've been talking about malaria significantly over the past week. We are reporting this malaria outbreak in Namibia. So yesterday and this morning, we were engaging the Ministry of Health to find out the best way to support. At this stage, 20 confirmed death has been reported out of the 1,551 admission. And as you can see, there's an increase in the number of confirmed by over 30%. And the challenge is that we have 0.6% of the pregnant women affected and 12% of the children. So knowing that those are the most vulnerable population, it's quite critical. And that's the reason why we had those conversations with the Minister of Health, emphasizing the different hotspots, Katima, Mulo, Andara, and so on, so that we can support it specifically on those hotspots, but also looking at the different strategies, the reactive individual spraying, also the continuous education in affected districts. As you know, malaria is also a disease due to the environment. So that education is critical. But to support the country, we are moving forward with a technical mission that will happen in the coming weeks. Next slide. Going to mpox now, the situation is still stable. We are moving from 111 cases to 143. We have a slight increase. As we see later, we still know the country where this is happening. So now that I mentioned we are learning the lesson from how we've been managing the mpox, in a few weeks, we'll have a dedicated time with the most affected countries, which we call an after-action review. Following the lift of the mpox as effects, we will sit down and ask the question with our member state, in your country, what went well? What went less well? And how do you think you will improve so that those are key components when you are now going to control the mpox at the national level. Those are critical lessons that the country have learned and need now to implement within the transition. Next slide. Namibia, we've just mentioned that they are now entering into the malaria outbreak while they are actually going out of the Mpox and Crimean Congo hemorrhagic fever. So as Mpox is concerned, there are no deaths. Only 3 cases has been reported. And this is a good indicator of how they've managed to deploy the active surveillance and really control the outbreak at the source. Now, in terms of Crimean Congo as well, you can see a small number of confirmed cases, 1 death, and the transmission was linked to the tick exposure, so the One Health approach. But you can see in both examples that the surveillance has been strong and therefore allowing the country to really control at the source. Next slide. Now we are moving to Comoros and Madagascar. In Comoros, we see the decrease, a slight decrease in the number of confirmed cases, moving from 6 to 1, 0 death, which is still very good. 27 confirmed cases are out of the 59 suspected cases. But the challenge that you can see here is the very high test positivity rate, meaning that all the positive patients have actually come by themselves to the health facility. So which also highlight that the active surveillance that we want to see in the community has not been happening. That is the reason why the team that will be supporting what will be living in the coming days, by next week, going there, will be really to support the country in those specific needs of improvement. The active surveillance, but also on the vaccination, the country, as you can see here, have been allocated 10,000 doses of vaccine. So they really need to know exactly where to use it in the hotspot, but also within the hotspot, which population are the ones that need to be targeted. Next slide. On the neighboring country of Madagascar, you can see still the increase in the number of confirmed cases, moving from 55 last week to 105, so almost 91% of increase, also, which is a positive sign because you also see that the test positivity rate is around 37%, which means that the active surveillance is being strengthened. And then when you strengthen the active surveillance, the integrate surveillance, then you also expect to have an increase in the number of confirmed cases, which is also showing that the laboratory is also following the surveillance and that integration. Now, the other part of the integration is the vaccination. So the country have started last week, we've mentioned it already, the vaccination, knowing that this is the first country in the continent to use the fractional dose approach, which means they use 1 dose and they can actually vaccinate 3 to 4 people. That is quite important, especially when we think about moving forward the herd immunity, when we think about ensuring that we protect most of the population in the most endemic countries, but also those innovations that will allow us to protect our population in a context where the resources are limited, where the vaccines are also in the short number. Now, this country, Madagascar, has also been affected by the cyclone, as you remember, and therefore to support the country both on the side of the cyclone, the Mpox, and to prevent other disease like cholera, which usually can happen after that kind of event, a mission of African Union will go to Madagascar next week, and then Africa CDC will be leading the health part of that mission. Next slide. In Liberia, we continue to monitor, and we can see the stabilization with a small number of cases, three last week, and then five the following week, still happening for the large majority in Montserrado. That's also where the upcoming 3rd round of vaccination will happen. So those are very good indicators that we are following. You can also see that the test positivity is pretty low, around 20%, which is showing that the active surveillance is happening, the vaccination is happening. So we look forward to continue seeing that stabilization over the day and over the week. Next slide. Now, on the issue of vaccination, as we do speak now, there is an important workshop happening in Addis at Africa CDC on the pre-marketing and the local manufacturing agenda, how the continent will be able to meet the need, the demand on medical countermeasure, which include the vaccine, the diagnostic, but also the personal protective equipment. So as vaccine is concerned, and for Mpox, we've managed to ship in 17 countries 5 million doses. 22 countries have granted regulatory approval. We've administered 2.72 million doses, 1.43 MVABN and 129 LC16 only in DRC through the bilateral support from the Japan government. And altogether, 2.63 million persons have been vaccinated. The difference that you can see is because at some point, some population was receiving 2 doses of vaccine. That was in the early stage. And then based on the evidence and also based on the challenge of the vaccine availability, we moved to the strategy of having 1 dose. And now even, as mentioned in Madagascar, to the fractional dose, where 1 dose can protect 3 to 4 people, based, of course, on the evidence that we've been having abroad, but also the research that Professor Mosoka would be able to say a word later on those different studies that will be moving forward the implementation of the vaccine. So at this point, we have 2 countries, Cameroon and Comoros, who have been allocated 10,000 doses of vaccine each. And as we do speak right now, the process of preparing the shipment, also the engaging the country is moving forward. So we believe that in the coming weeks, the vaccine will be in country and then will have the impact that we expect, knowing, of course, that the vaccine is not a silver bullet, but is a tool that will come to complement the other measure. Next slide. Now, this slide highlights the challenge that we've seen in vaccine delivery. So those that you see in green are the countries that have managed to absorb the large majority, more than 70%, more than 70% of the dose that they've received. And you have the countries that are still in active phase, and others like Sierra Leone, Rwanda, who have actually been now on the control phase or at the end of the outbreaks. But those you see in red are the countries that are really challenging in using those very expensive doses of vaccine. Now, there are many reasons for that. The first one is in some of those countries, as you can see, which is the case of Angola, they are the control phase actually moving toward the end of the outbreak. So it makes it difficult for them, which is also a bit similar with South Africa, where you see that they've reported 2 cases in 2026. And this low number of cases is a limitation for the commitment, the engagement of the communities themselves to go and receive the vaccine. So that's one challenge. The second one is that we've been supported by Gavi. Gavi that has been provided Mpox country delivering funding support for up to $12 million. That is a large amount of money. However, these funds at some point were no longer available, and country now had the charge to invest on the fund to deliver the vaccine to the community. And this is what Uganda has been doing. As you can see, Uganda has been using 88% of the vaccine received, and the large majority, almost three-quarter has been used without the funding. That was domestic funding, and which is a good example on how we are moving toward increasing the capacity of country to invest in their health. Next slide. Now moving to cholera that we see in the continent. We have those two member states that the one that are the most critically affected. But in terms of change, we have Zambia and Angola, where the cases have increased in the most 3 weeks. And we have those where we see some decrease, like DRC, though when you look at the actual number, DRC, Mozambique, they still support a large proportion of the case, but also the death. Next slide. In DRC, as I was talking about, they contribute today to 70% of the case and almost 90%, 85% of the death, depending on the weeks. The challenge that the country is facing, they are dealing with protracted conflict and displaced millions into overcrowded camp, leading to poor sanitation, but also large challenge of dealing with many other outbreaks. Last time we were talking about the meningitis, we are also talking about the mpox, quite a number of outbreaks that they have to handle at the same time. This is also a challenge. Nevertheless, the country is really pushing to use all the tools available between the reactive vaccination, which is the vaccine that are used to respond to the outbreak. This is what will happen in Okatanga, but also in Lualaba and Manica, and also Kinshasa, while they are also planning the preventive vaccination. This is the one that is implemented with 2 doses of vaccine, and that provide a longer immunity to the community. So ideally, we want to strengthen, to scale the preventive vaccination so that we give time to countries, not only DRC, to countries to work on building, strengthening the infrastructure specifically or especially, or to prioritize the zone that are endemic for cholera, so that whenever there is an outbreak, the number will be limited because the access to water and latrine will be of quality. Next slide. Now in Mozambique, you can see that there have been an increased trend. So for the last 3 weeks, we've seen that decrease. Last week we were having 610. Now we have 713. We are still a bit stable as compared to 5-6 weeks ago, where we were having that high peak in terms of number of cases, but also in terms of number of deaths. So quite a number of effort has been put in Mozambique. First of all, the vaccination. Mention once again the preventive with 1.7 million, but also the reactive, where they are targeting the 3.3 million. So on one side, they control the spread. On the other side, they prevent in districts that have not yet been touched, but which are they known to be high risk. So they are using the 2 approach. But also in terms of case management, to ensure that they keep the case fatality rate below the 1%, they are strengthening the cholera treatment center that are established by MOH and the partner. On top of that, cholera is the disease of hygiene and water. The distribution of kits in the hotspot is also happening. And to support Mozambique and the country within that region, we'll have that mission that will be going hopefully next week to really to support on the WASH, but also on the surveillance and the case management. Next slide. In Angola, we follow how the situation is moving, and that's why we decide to put that slide. Though the number, as we do speak now, it's not that important. Angola is quite specific because within a year, we've seen those 2 rounds of the cholera outbreak. So now when we see a number of cases, it's important to go and discuss with the country on how these can be addressed as soon as possible, so that we don't see what we saw during the first one. And that discussion will lead to scaling up the WASH in those places, but also pushing, advocating for the preventive vaccination in districts that may be neighboring the district that has been affected. So that coordination is strong around the partners, and then we believe that in the coming weeks we'll be in a position to increase the OCV coverage, because now the coverage has exceeded the 3.57 million people, but as you can see, there might still be more. And that also push once again our agenda of the local manufacturing, because the dose of cholera vaccine have increased. That's really good and need to appreciate that, but we are still below the quantity of those vaccines that the continent is in need. Next slide. Cholera in Burundi. Last week we were highlighting the effort of Burundi to move at all levels, at the political level, with the engagement of the head of state and the first lady, who are going in the field with the different partners. So this week was the opportunity of the WHO regional director to visit with all the other partners who are also part of the IMST, to go and see firsthand how the situation have evolved in Burundi, and more specifically on those refugee camps. So gladly so, the case fatality rate is in Burundi is pretty low, 0.4%. They've been reporting 16 deaths out of the 4,000 cases. Now, in terms of effort that the country is pushing, really the surveillance and the contact tracing, but the provision of drinking water, that's the key challenge, access to high quality potable water. But in supporting the colleague, the healthcare workers working, there are some integrated training that are happening currently. The strong coordination is emphasized at the country level, but also and more critically at the partners level. That's why we are here in Kinshasa, see how we can keep on strengthening, we can formalize this platform to ensure that whichever public health event is coming, we go at once. When we are talking about preparedness, also we go at once, so that we reduce, we increase the efficiency of the resource that we are using, but more critically, the support bringing to the member state is clear. Next slide. Now, to summarize, we can say that this week is quite intense on the reshaping the agenda of the response to public health event with this workshop happening in Kinshasa. Will come out with strong recommendation and actually a framework. We start with the one from the response, and then we engage the colleague working on the preparedness so that we can come with a whole framework. Now, on top of that, we have those engagement to strengthen our partnership with the ECDC, the Japan Institute of Health, to ensure that Africa CDC has the capacity, the skills, and building on all our expertise to ensure that we provide what the country are in needs. So as mpox is concerned, we still have currently the focus countries, Madagascar, which you've seen, but also Liberia, where we see some progress. We also have the allocation to the vaccine, Comoros, Cameroon, which is about to come. As cholera is concerned, the increased transmission in Southern Africa re-highlight, if needed, the joint approach, which will happen in the coming weeks, while DRC remain the leading country in the continent through 64% of all cases and more or less 85% of the death. So I will stop there, and I will be happy with my colleague to answer any question that will be coming from our journalists. Thank you.
Thank you very much, Prof. Let's take the first two questions. We have one here from Farai Msaka of the Associated Press. The question is, what is the situation regarding the impact of the United States-Iran war on Africa's health and humanitarian situation? Are there any African countries or regions affected by supply chain disruptions related to the war and actions taken by the Africa CDC? That is the first question. The second question is from Jacob Achworth, who asks what sustainable financing strategies are being implemented to ensure countries can respond to health emergencies without relying solely on donor funding. I'll pass the floor back to you, Prof.
Sorry, I did not get the second question.
Right, okay. So this is Jacob Achworth. The question is, what sustainable financing strategies are being implemented to ensure countries can respond to health emergencies without relying solely on donor funding?
Okay, thank you. So for the first one, it's on the war of US and Iran. I think we are all affected in one way or the other. We have some colleagues who are highlighting that in some countries where they are deployed, the fact that the oil is increased might be challenging for some of the logistical deployment. However, we are still in the process of having a clear assessment on understanding on how our operation and our partners' operation are being affected. But altogether, it's still pushing the agenda of the local manufacturing, because we need to have the stockpile of our medical countermeasures so that we are less affected by the global crisis. So once we have a better understanding, most likely next week we'll provide more granular data on that. So in terms of the sustainable financing strategy that we are applying in countries, the first one is to ensure that the countries has the expertise. That's the reason why we are deploying 20 financial experts in the top priority countries as per now. DRC is one of them. And then we had last week the approval of the Minister of Health on the profile that was proposed to him, so that that person will be the one sitting with him, supporting on and advising on what strategy can be implemented in the country. I take the example of DRC because this is also the country that have launched that 2% taxes on import goods. And these 2% will now go in the Ministry of Health fund so that it can increase the budget of the country. Third is the reduction of the inefficiency. This is also with that technical expertise to identify in the countries where are the gap. One example are the ghost workers. We've been using that example again and again. The DRC is losing $800 million every year because of those ghost workers. They are not working, but somehow they are paid. So the digitalization of that will allow to reduce on some of those inefficiency and then provide significant amount of money to the country. But now, even when that money is coming, they need to have one plan. This is something critical that we are supporting. How countries can have one health plan instead of having one plan for HIV, one for TB, and so on. So all that is happening. The last but not the least, and that's the reason why our Director General recruited a special advisor on debt swap. How can we use the debt as a way to invest now into the health? This is one of the opportunities that we are seeing to sustain the financing of healthcare in the continent.
Thank you, Prof. Let's cross over to the floor. We have Esther Nakazia, science journalist from Uganda. Esther, you have the floor.
Thank you, Margaret, and thank you, Professor, for this talk. I have two questions. The first one is about the MOUs we have signed. Africa CDC has signed with Japan and the EU. Is this a knee-jerk reaction from these two entities because we have bilateral health deals with the EU?
Esther, we lost you, Esther, there a bit.
Can you hear me?
Yeah, we can hear you now.
Okay, so can we get an understanding of what is in these MOUs that Africa CDC is signing with Japan and EU? My second question is about fractionalizing mpox vaccines in Madagascar. How for people? Can you hear me?
Yeah, could you repeat, go again on the Madagascar question?
Yes, Professor said that one vial, Madagascar is one of the first countries to do fractionalizing of mpox vaccines in Africa. And I wonder, he said one vial can go between 3 or 4 people. What qualifies 3 or 4 people? How does fractionalizing actually work when it is being done? Thank you so much.
Back to you, Prof.
Thank you. Thank you so much, Esther. So the first question on the MOUs was what is in those MOUs? So it's, the core of Africa CDC, our DNA initially is the preparation, prevention of, and response to outbreaks. So which really include the surveillance, the research, the workforce development. That's one. but also basing on our previous experience. As mentioned, we've been working for almost a decade with ECDC, either on the building our capacity or just working together. We were having some colleagues from ECDC here in Kinshasa responding either to Mpox or to Ebola. So the idea was now to formalize that so that we have a proper framework on how we'll be engaging in the future based on the experience that we had. So that is mainly what is part of those framework. And this is also part of the current vision that we have and that we are pushing here with the IMST, where you have a large number of partners with different expertise coming all together with the convening power of Africa CDC to ensure that we provide adequate support to our member state. So some will come for strong surveillance, other will come with the vaccine, other will come with research. And when bringing all of them together under one coordination led by WHO and Africa CDC, then we'll be able to ensure that the country have the exact support that they need, especially in this area where the funds are limited. For the fractional dose, I will give to Dr. Charles Ibeneme, who is the lead for the pillar, which was actually talking this morning with the colleague from Madagascar on how the vaccination is going. Over to you, Charles.
Yes, thank you so much, Prof. And thank you for that very wonderful question. So I guess it's basically looking at the aesthetics in terms of what is driving the number of doses you can get from a vial while you deploy the fractional dose. So WHO SAGE recommendation did recommend that for fractional dose, you will be able to draw at least 4 doses. This is 4 doses per vial using the 0.1 mil. This is to allow for room for wastages. And the difference in either 3 doses or 4 doses is now dependent on the healthcare worker, on the healthcare worker itself, because we know different healthcare workers, and depending on their training, have different ability to draw within the vial. Basically, when you use a 0.1 mil syringe to draw vaccines, there is that tendency of having air in between as well. So it's all about the healthcare worker capacity to be able to draw those vials. That is why you are having some draw for 3, some draw for 4. However, like I did mention, the guidance is to have at least 3. So this is something, it is not something we did not expect, and it is not unusual to draw either 3 or 4. So they are all, it's part of the calculation which we did in terms of the forecasting of the vaccine. So just to mention that it is not unusual, and it is quite expected in that regard. Thank you, and back to you.
Yes, and maybe Dr. Mosoka can add a bit on the research component for the fractional dose. Dr. Mosoka?
Thank you so much, Dr. Yap. So the issue of fractional dose actually started, US, and the US launched a multi-country trial that showed that you could give, so normally it's 0.5 mil, but you could give 1 mil of the vaccines instead of the 4 dose. And the key thing was, is it as effective as the 1 dose? Does it elicit the same type of antibody response? And what the consistent studies have shown in the US, in the UK, was that you could give the vaccine at 0.1 and 0.5, you have the same type of immune response, and the durability will be the same. But it hasn't been tested on the African continent to show how it works among the African population. But in countries like the US, is well established. They've done the research and show that you can get similar results. So what does that really mean? It means that we can save almost 80% and still get the same immune response, the same protection. So this is very critical for us to show that we are not trying in the African population with established data. We are setting up the protocol to look at the effectiveness of the 0.1 to 0.5. But the science is there, it's solid. It's solid. It shows in other countries that you can give 0.1 in the skin, intradermal, and then 0.5 subcut and get the same result in terms of protection and durability. Thank you.
Thank you.
Sorry, Margaret, I have a follow-up question, a very short one. What is the type of dose the type of vaccine that is being used in Madagascar?
Prof?
Yes, I think Charles may have the exact answer.
MVABN vaccines are being used. Recall, we have 2 vaccines being used in this response as a whole, MVABN and LC16, but LC16 has only been deployed in DRC. So every other country on the continent have been using MVABN. Thank you, and over.
Thank you,
Thank
Dr.
you.
Charles. Let's take the next question. We have Gabriel Emmanuel from NPR. Gabriel, you have the floor.
Hi, thank you so much for doing this as always. I wanted to ask about the WHO has spoken about how the war in the Middle East has impacted the health systems there. And I wanted to find out what the impact has been, if any, on African countries, North African countries, the whole continent. Thank you.
Thank you, Prof.
Yes, as mentioned, we are yet to have the magnitude of the way the continent has been impacted. But as you can imagine, the medical countermeasures that are imported in the continent can also suffer for what is happening. So the granularity of that is being worked on, and I believe that next week we will be able to provide more information about it.
Okay, let's take the next 2 questions. I have one here from Dele. The question is, in the face of dwindling donor funding, can Africa establish a sovereign fund for health emergencies? If so, what would be the procedure? So that is the first question. We have another one here that is focused on Liberia ending the long-sustained measles outbreak. So the question is, what support is Africa CDC providing to Liberia in ending the long-sustained measles outbreak? Back to you, Prof.
Okay, thank you. So the question on the Liberia and the support that we've been bringing, I will let my colleague Rajabu, you remember I've highlighted the AVOC program, which is the critical program on how we build capacity in country to respond, not specifically to this outbreak, but to many others. So we will be able to answer that one. So now the question on the donor funding, if you recall, we've mentioned last year the African Epidemic Fund, or AFEF. So this is a rapid financing mechanism that is established by the African Union and our CDC to really support flexible funding for public health emergency across the continent. So the idea is, how can we have available fund so that within 48 hours, we can deploy team in countries, we can deploy the human resource, we can deploy the medical countermeasure, whether the rapid diagnostic test or any laboratory test, whether we are talking about drugs, whether we are talking about PPE, personal protective equipment. To bring all those on within 48 hours, we deploy a team which has the fund to react, because that's the best time where you can have an impact. So this fund will also support the preparedness, not only the response, the preparedness, how we, in time of peace, allow country to continue, for example, the lab decentralization, but also to building of the capacity of the EOCs as we've been supporting. So the idea is really to have a continent that is not only safe, but sovereign. So the AFEF is really the tool that we believe will provide us that flexibility, that rapidity on deployment in many countries. And that is a fund that is being made with the contribution of the member states and others under the leadership of Africa CDC. So now on the question on the Liberia, my colleague Rajabu, I think Rajabu is connected.
Yes, Prof. Good afternoon. So I think if Director can come up, because also breaking with the full questions, please.
Yes, let me get it. So there's a question on measles outbreak in Liberia. I seem to have lost it.
The question was, what was the contribution of Africa CDC on supporting Liberia in responding to that outbreak? And I was highlighting that you can mention how the AVOC and others has been implemented, not only for measles, but for all those outbreak response.
No, thank you very much, Prof. I think you nailed it. So for us, as AVOC Prof has highlighted this health emergency workforce for health emergency, continental health emergency workforce. So we've been supporting Liberia and other countries like Sierra Leone during the for mpox response, but also some other additional countries. This is health emergency workforce to support countries to deal with emergencies like the measles in Liberia. And remember, what we normally do is as local as possible, as international as necessary. So in Liberia, we supported in the measles, especially in surveillance and outbreak investigations, in supporting the countries to ensure that all the cases are investigated, and also Liberia is supported fully to tackle the measles outbreak like any other countries that we have that are reporting the measles outbreak. So I think let me pause there. But this is just one of the countries that we're supporting in measles response. Over.
Yes, and I can also add, beyond that support from the human resource and the AVO, when you strengthen the capacity of the country to the establishment and reinforcement of the National Public Health Institute, it's giving to the country the capacity to respond to different outbreaks, including measles. Also, when you support a country in lab decentralization and improving the capacity for molecular, for sequencing, it's also contributing. So sometimes you may not see a specific support for one disease, but having in mind that strengthening the coordination and some of those critical departments are also in a way an opportunity to strengthen the system so that it can respond to any type of public health emergency.
Great, thank you, Prof. Let's take the next question here. We have one from, let me see. We have one here from Frank in Tanzania. The question is, what are the considerations and potential risks of administering the mpox vaccine to immunocompromised individuals, particularly people living with HIV whose immune systems are already compromised by infection? So that is the first question. The second one here is on the epidemic situation in DRC. The province of Equator, there is an outbreak. There's an outbreak of cholera. So more specifically in 3 health zones. Interventions are minimal and are not sufficient to contain this epidemic. What actions are being taken? Back to you, Prof.
Okay, thank you. For the question on the mpox vaccine, I will let Charles answer, and I might come back unless Papa also have some few to complement, and I will come back to the question on cholera. Over to you, Dr. Charles.
Yes, thank you so much, Prof. I was just trying to put on my camera. Yeah, thank you for that question. So far in this response, we've, of course, you're aware that WHO expert committee, SAGE strategic committee did recommend the use of MVABN and even LC16 for all persons aged 1 year and above. There is no contraindication for persons with that are immune compromised. So so far from the data we've also received, we've not had any serious cases falling within that bracket. For now, we do not see it as being risk to that particular population. The same goes as well to pregnant women and lactating mothers as well. What we've not been able to ascertain across countries is the deployment of the vaccines in ages from less than 1. And I think that is what some studies are currently ongoing, especially in the DRC, with support from CEPI to do some studies in terms of tolerance of the vaccine in ages from 1 year to from within I think 1 to 4 months, and also above from 1 year to 2 years. But basically, from what we've seen, from data that we've seen, and just from the result of the cohort monitoring that has been done, we've not seen any risk within that population. Over to you, Prof.
Yes, thank you so much, Charles. So to the question, the specific question of cholera in DRC, that's a very good question. Why? Because Equateur has been also a place known for the outbreak of Ebola at some point, and also Mpox. So this is a place where you have those multiple outbreaks occurring, which now include cholera. So there are many ways of supporting the response to cholera. The first one, the very first one, is the political engagement. You remember I mentioning that a few weeks ago, we are having our Director General here in DRC to engage at the highest level of the country, emphasizing how critical it is for the country to support the investment into health. And cholera is one of them. When we talk about the taxes that will be now supporting the Ministry of Health activities, it also includes how they are going to respond to those outbreaks with the support actually relying on the National Public Health Institute, which is really the one responding, controlling to those ones. But in terms of the operation, the action, what is happening currently is the planning for the different type of vaccination campaign. So one is the preventive, where they will vaccinate in districts that are currently not into outbreaks, so that in case there is a spread, they will be able to be immunized. And also now in those who are currently affected, Equateur is not the top one. The top one are the one in the Kivus, but also Kinshasa and so on. So those ones are the ones that are prioritized for the reactive vaccination, where we believe that giving at least one dose will kind of limit the spread of the disease. But at all, we talk about the vaccination, we talk about the political engagement, but it's still the issue of access to water. So in the Equateur, like in others, you may be aware of the project Fleuve Sans Choléra. So some of those initiatives are important coming from the country to see how they can address the fact that the cholera is moving around the Congo River, but also without that line. So that's why it's critical to look the country from a different perspective. And last but not the least is how to intensify the surveillance in those Equateur, but also many others. The way we did it on Mpox, we are having a meeting this week as well with colleagues from UNICEF, WHO, but also LTI, to see how in those places, the one you've mentioned, we can really intensify the response. But this needs some resources, which will also come from the awareness and the political advocacy that we are currently doing at the national level, but also at the continental level.
Thank you, Prof. One last question here on local manufacturing workshop that's going on at Africa CDC. The question is, are there any concrete steps or timelines that are being discussed to expand African production of vaccines, diagnostics, or PPE for outbreaks such as Mpox and cholera? Back to you, Prof.
So the actual timeline I've not all set. As you know, as I mentioned, the workshop started today. So there will be those engagement discussion until tomorrow. That is one. Two, however, we already have some clear timeline on the next extraordinary summit, which will happen before the month of June in Nairobi under the leadership of the president of Kenya, to ensure that we bring now all at the political level, all the one engaged on local manufacturing. So between this workshop, which is actually a critical milestone moving toward that summit, the colleagues will discuss. And this morning, I was one in the panel to see how on our side of Mpox, cholera, and public health emergency, what are the critical needs? When we say that we want to protect Mpox in the countries that are endemic, what are we talking about? How many millions of people will need to have the vaccine, the Mpox vaccine, so that we will reach the herd immunity? And those predictions will now guide the producer to say, we need 10 million of those doses in the next 3 to 4 years. So how are we going to accelerate the local manufacturing? Because the manufacturing depends on the demand. So if the demand is there and the funds are there to support that, then it's a big incentive for the manufacturer to produce at the local level. So we keep on following, and next week we can provide a good understanding and a recommendation from this workshop.
Thank you, Prof. And with that, we have come to the end of the briefing this week. I'll hand over the floor back to you for your closing remarks.
Thank you, Director. It has been a pleasure to engage with the journalists, but also, as mentioned, all the other colleagues, scientists, public health experts who are live, but also who will be watching this press briefing later on. It's also an opportunity for me to thank all the colleagues who are here during this week to rethink on how we can strengthen the collaboration, the coordination with the WHO, UNICEF, Gavi, AHSS, and all those partners on how we can improve from the lesson we've learned, the response and the preparedness to outbreak and public health event in the continent. And also those who are in the field fighting against cholera, fighting against all those diseases, it's also an opportunity to appreciate. And last but not the least, to the journalists, we are here, you are here to ensure that we have the accountability, the transparency, and then we'll be grateful to see you next week at the same time. Thank you.